Hi, I'm Dr. Tom Lewis, founder of Real Health Innovations and a medical scientist with credentials from MIT and the Harvard School of Public Health. Today I'd like to talk to you about how Real Health measures chronic diseases. The problem we have in society today is our healthcare system is really focused on acute diseases, immediate, sudden diseases, but we're not putting enough emphasis on predicting and understanding risk of chronic diseases, which actually is rampant in our society. So let me give you a little rundown of exactly how we do this. So first of all, we do biometric testing like everybody else, but it's really a question of what tests we do and how we interpret those tests that differentiate us in terms of understanding your chronic disease risk. So yes, we do blood testing as well as everybody else, and we also do eye testing. Why eye testing? I thought an eye test was just to study the health of your eye. Well, actually your eye is a window to your health, and we're actually measuring tissue and pathology. We're actually doing a living biopsy when we measure the eye. So in the blood testing, we're doing common biometric measures that everybody else is doing as well. White blood cell counts and liver function. But we're also looking at some markers that aren't as commonly run, like C-reactive protein and homocysteine. I'll get into that. So that's physiology, but physiology is actually quite far away from disease. Your physiology can change a little bit and then recover. But in the eye, when we see actual tissue changes, that means you really are progressing in a disease state. So we couple these two tests together. So why do you want to have chronic disease testing done? Well, here are three very prominent individuals: Jimmy Lee, a high-level investment banker, David Goldberg, and Tim Russert. All these folks died suddenly. Now they had a heart attack or some other severe condition that led to the end of their life. So I ask you, in Tim Russert's case, who had a heart attack, was he healthy the moment, the minute, the hour, the month, the year, even the decade before he had that heart attack? No, he was slowly progressing in a state that made him vulnerable for that tragic event. So we've developed a very simple test based on biomarkers that we call your chronic disease temperature, or CDT. And it tells you where you are on this health disease continuum. And I'd like to explain to you how we use the CDT and what it's all about. So rather than go into all of the details of the CDT, it includes 40 different biomarkers. We don't test them all on every individual, but here's a very simple one, white blood cell counts. And white blood cells are going around in our bloodstream looking for invaders, looking for toxicity, looking for things that are compromising our health. And it's a very standard test. It's really a measure of our immune system working. And depending on the laboratory, a white blood cell count is as inexpensive as $2. So if we look at it in the standard of care, and these numbers here would be just simple counts, the number of white blood cells per unit volume, the normal range is around 3,500 to somewhere around 11,000, and it varies from lab to lab, but it basically falls in this range. And if you're outside of this range, there's a high likelihood that you're going to be sick very soon or already are sick. Now, from a chronic perspective, we're worried about what's going to happen to you in 5 years from now, in 10 years from now, or even a year from now. So the RHI, the Real Health Innovations normal, is 4,000 to 6,000. Anything outside this range we consider abnormal from a chronic perspective. And you can see anywhere in the red, we're saying you're abnormal, whereas the standard of care doctors are saying you're completely normal. I'd like to explain what our normal values are based on. We have combed the literature and done an exhaustive search, in fact, $2.5 trillion worth of research, and anything outside our normal, there are statistically valid studies that shows a person in this regime or this regime, which is considered normal, have an increase in early mortality risk. And in fact, the classic study is the Women's Health Study, Women's Health Initiative, where if you have two women, a group at 6,700, well within normal, versus 4,700, these women have a 50% increase in mortality in a scant 6 years. So it's a severe difference in chronic disease risk. So from a chronic perspective, you need to be looking at this range, not the standard of care range. So what we also do, we provide a value for your chronic disease temperature, white blood cells being one of the values that contribute to it. And we use the same scale as measuring your core temperature, 98.6. Anything above 98.6 in our chronic disease temperature module means you have an increased statistical risk and early mortality. So what we do with the white blood cells, for example, is we've looked at the literature, and any value above our normal is assigned additional temperature increments. And I know we're showing 7,000, 8,000, 9,000, but we've looked at the studies to see where is the next jump in statistically validated mortality. And we scaled that according to that. So for example, if you're at 10,000, which is in the normal range, we're going to add about a half a degree temperature increment to your chronic disease temperature. So it's scaled to your mortality risk. So rather than going into a whole bunch of our chronic disease temperature parameters, I just want to go over a few with you, which is on the next slide. So white blood cells is immunity and infection. Cancer, everybody's worried about cancer. And what we do in society today is we wait till we detect the tumor and then treat the tumor. But there's something underlying the tumor. What caused the tumor to proliferate in your body? Well, it turns out that NLR, which is an abbreviation for neutrophil to lymphocyte ratio, a $4 test, is an extremely strong predictor of your cancer prognosis and susceptibility. So we've looked at neutrophil to lymphocyte values to see how this number changes and your cancer risk increases, and assigned a chronic disease temperature increment to these values. Homocysteine, abbreviated HCY, vascular health and heart attacks is really the main predictor for homocysteine. Homocysteine is a much more profound predictor of your future risk for a heart attack compared to cholesterol. So we use that. And the famous Framingham study now shows that for every 5 units of homocysteine increase in your blood, your risk of getting dementia, Alzheimer's increases by 40%. So insulin and diabetes, when people are measuring A1C, A1C is after the fact. The first thing that goes up in your body is your insulin level. You become insulin resistant. This is when you want to start taking action to reverse that condition, not when you're a full-blown diabetic. Fibrinogen, it's a blood clotting factor. So people have stroke. What are we doing in the standard of care? We're lowering blood pressure for fear that the arteries are going to burst or whatever. But the real issue is clotting. Fibrinogen is a very good marker of clotting factor, and we know what threshold of fibrinogen is indicative of increased mortality risk. And just like with the white blood cells, that value is well within the standard of care norms. Where you consider normal, we consider you abnormal. And then vitamin D. It's considered important for bone health, but it's also important for immunity. The threshold limit in the standard of care is 30 nanograms per milliliter. We want you to be at least 60 or 65. If you look at groups of people at 30, which is completely normal, versus 65, the people with a level of vitamin D at 65 have much less cancer and have much less chronic disease. Flus are not as severe, a whole myriad of health factors tied to immunity. So the value of the CDT, the chronic disease temperature, is we're amplifying the laboratory values so that we can see where you are on a chronic disease risk scale. It's a single understandable value for complex labs, so we can take the neutrophil, the lymphocyte, and the white blood cell and the fibrinogen and combine it into a single value. That value is your risk value. We want that value to go down. You want that value to go down. It's a way for you to measure how well we're doing. It's extremely sensitive for prevention. I call it a blood test or a biometric amplification tool. It's tied to your overall health and inflammation, and in fact, it's tied to your increased risk of mortality. You can measure your doctor and your care team, and of course, your care team can measure you, because if your chronic disease temperature is not coming down, maybe you're not doing what you're supposed to do, or maybe your doctor hasn't found out the real root cause to really affect that improvement in your health. And lower your CDT, lower your chronic disease temperature, lower those blood values, and your health will improve. My name is Dr. Tom Lewis. I'm founder of Real Health Innovations. The whole purpose of Real Health Innovations is to measure your chronic disease burden and help you eliminate it so you can have a longer, healthier life. Thank you very much.